Supervised Methods for Classification for Parkinson's and Heart Disease Datasets by Kenneth Rexer and Mary Visca. As healthcare organizations pursue more personalized approaches to patient care, the ability to potentially predict that someone has a disease or is likely to contract it will become more important. Abnormal variations in voice frequency, also known as dysphonia, are valuable to the diagnosis and monitoring of Parkinson's disease. These can be measured and tracked remotely, reducing expenses to both patients and healthcare providers. Classification methods that use this data to discriminate between a healthy patient and a patient with Parkinson's disease, or to monitor the progression of this disease, could be valuable. The dataset we are using contains 195 biomedical voice measurements from 31 people. Measurements are fundamental frequencies, amplitude, tone-to-noise ratio, which is used to quantify the presence of distinctly audible tones in a sound signal, signal fractal scaling exponent, and diagnosis of Parkinson's disease. According to the World Health Organization, heart disease is the leading cause of both men and women worldwide. Providing a tool that predicts if someone has heart disease based on a few simple measurements could save lives. Our data has 303 observations and 14 features. These measurements include age, sex, chest pain type, resting blood pressure, serum cholesterol, resting ECG results, length of exercise test, exercise-induced measurements, number of major vessels, whether the patient has thalassemia, a hereditary blood disorder, and diagnosis of heart disease. Classification methods that have already been studied in diagnosis of Parkinson's disease are random forest and support vector machine. We would like to test a more robust field of algorithms for a more comparative study. In previous studies for heart disease, support vector machine outperformed random forest, artificial neural network, and naive Bayes. We are adding logistic regression because it has been shown to perform well in the prediction of coronary artery disease. In addition, these are all algorithms covered in this course, so we are familiar with their implementations. This flowchart illustrates our proposed research plan. We will attempt principal component analysis for dimensionality reduction on each dataset and see if it improves the accuracy of the model. Then we will run base models for each of the chosen algorithms. We will then tune the parameters for each model in an attempt to improve in performance. Finally, we will compare results within each model and across steps of our plan to assess improvement.
We have run 10 iterations for each classifier, both before and after parameter tuning. On the heart disease dataset, logistic regression scored the highest average accuracy before tuning. However, random forest outperformed logistic regression after tuning its parameters. For the Parkinson's disease dataset, once again, we find that random forest scored the highest with an average of 86% accuracy. Here, we compare the training accuracy versus the testing accuracy. Support vector machines, which consistently scored the lowest average accuracy on the testing data, was an overfit model with nearly 100% accuracy on the training data. By computing the F1 and area under the curve score for each classifier, we continue to see random forest scoring the highest out of any model. Therefore, we conclude that random forest is the best classifier for both datasets. Further research which could be taken would be to generalize our study. By classifying datasets according to their features, one could immediately identify the best model for any dataset.